Today we'll be talking about the physiology of the puerperium, or postpartum. So as an overview for this lecture, we'll be talking about changes in the postpartum period, also known as the puerperium. And we'll look at how the uterus changes, as well as specifically the endometrium and the placental site. That will include uterine vessels as well. Then we'll move on down to the lower part of the uterus, looking at the cervix and the changes that undergoes, vagina and perineum, and then also looking at the peritoneum and abdominal wall and how they readjust to the pre-pregnancy state or our new normal state. And then we'll take a look at how the urinary tract, endocrine system, cardiovascular system, and urinary tract also change to reach back to what our new normal is going to be. So that's how we want to think of this, is we're reaching a new definition of what our normal non-pregnant state is. So it's the time after childbirth, typically lasts about 6 to 12 weeks. Though we do like to say for full recovery after a pregnancy, we like to think of that as a postpartum year. So have that in the back of your mind, though a more formal definition of the puerperium time period would be 6 to 12 weeks. So there's anatomic and physiologic changes that are brought about by pregnancy, and we're looking at how those changes end up resolving postpartum. And it's also how women are adjusting to motherhood and readjusting to no longer being pregnant. So the majority of this lecture is regarding the physical changes, but we do want to keep in mind social changes, psychological changes, spiritual changes as well. So postpartum involution, that's in reference to the uterus shrinking back down to size in a nutshell. So we have strong, sustained contractions for about 1 to 12 hours right after the birth. And then they do tend to slightly relax after that point, and then it's slowed continued contractions back down to the regular size. So we initially have that period with really strong contractions that can be pretty uncomfortable. And then once we have that slight relaxation, we're not really at an increased risk for bleeding at that point, because by that time our blood vessels that were feeding the placenta should have clotted off, so we shouldn't be at a high risk for that any longer, bleeding from that site. So at birth, you can find the fundus at about the height of the umbilicus or the umbilicus, and then each day afterwards, it's about a finger breadth lower. So it goes down a finger each day, and then usually by 10 to 12 days, you can't find it anymore, and then the uterus returns to the pelvis by 2 weeks. So you think about if you have a mom who's 2 weeks postpartum and she's having really heavy bleeding, and you're having her come in and you're finding that you can feel her fundus for one, but that it's maybe halfway between her pubic bone and her umbilicus. That's not involuting fast enough, and there's probably something going on there that's causing her increased bleeding, and those things would be related. So having a sense in your mind of what normal involution is, we want to know what our normal is really well, so that if something's not normal, it'll stand out to us. It's easier to learn what normal is than to constantly have in our mind what not normal is. So, okay. So then we're back to a normal, non-pregnant size by about 4 to 6 weeks postpartum. So that involves an autolysis of extra actin and myosin to get back down to size. And it's occurring primarily, though, by reducing the cell size. So we thought about how when our uterus got bigger to support pregnancy, we had cells, uterine cells that were undergoing both hypertrophy as well as hyperplasia. So there were more cells, and those cells were getting bigger. Whereas now, to get back down to size, that's primarily done by shrinking those cells, not by reducing the number of cells. The uterus may take longer to become as firm as a non-pregnant uterus. So longer than that 4 to 6 weeks. So that's just something to keep in mind, I think about especially with IUD placements. If a woman is postpartum when you're putting it in, for starters, it's easier to get it in because her cervix is still kind of soft and open a little bit. So that makes for an easier insertion. Because the cervix is still a little bit softer and more open, you're more likely to have an IUD expulsion where you put it in and then, a week later it falls back out again. But then because the uterine wall is also not as firm as it is in a non-pregnant state, there's a higher risk for a perforation where the IUD goes through the uterine wall and into the abdominal cavity. So that's not a contraindication for giving it. You can certainly put them in postpartum, but to be aware that there is a higher risk for both IUD expulsion as well as perforation in postpartum women. Okay, so how about the endometrium itself within the uterus? What kind of changes is that undergoing? So the whole reason that the placenta comes out is because the baby comes out and then you have that decompression with all that extra open space where the uterus starts to shrink back down to size, and that causes the placenta to start to shear off of the lining, right? So we have a decrease in surface area, that total surface area, especially once the placenta is out. Far less surface area for the endometrial lining. And then hemostasis is achieved primarily by smooth muscle contraction within the uterus. And we know that those uterine blood vessels are running through that smooth muscle. So as the smooth muscle contracts, that's cutting off those blood vessels that are within it. So we don't hemorrhage. And then we have an immediate inflammatory reaction for about 10 days after the birth that actually helps to provide an antibacterial barrier. You think about all that open wound space from the surface area where the placenta was being exposed, and the potential for contamination in that time when usually the uterus is a pretty sterile environment when you think about the cervix being tightly closed and there being mucus in the cervix. There's typically not anything going on up there, but to be dilated all the way to 10 centimeters and everything else that could happen around a birth, I think especially if like a manual removal for the placenta was needed, if the placenta wasn't coming off because mom was hemorrhaging and the midwife reached in her hand and carefully scooped the placenta off of the uterine wall and took it out. It doesn't happen very often, but it can happen. That would be more exposure to bacteria. So you can think about how the experience of birth potentially is opening up the mother to infection. But this immediate inflammatory reaction helps provide some cushion or protection for that. And then we think about our endometrial glands needing to eventually come back in order to think about a future menstrual cycle. Those glands start reappearing by 7 days, part of just what makes up the endometrial lining. And then the restoration of the endometrium takes about 16 days, but that placental site will take longer. That's about 6 weeks, and then our placental site is basically healed and good to go. But we do want to think about anytime a placenta was there, there is a little bit of scarring, and that site never completely heals. It's healed, but there is some scarring. It isn't completely back to what it was prior to the pregnancy. So thinking about that space as being a location that would put that mom at a slightly increased risk for a necreta later on in future pregnancies. So you have one baby, the tiniest increase for your next baby, and then think if you have a woman who's had a lot of pregnancies before, then sorry, my cats are jumping all over my bed and it's kind of distracting. Lots of pregnancies, that would increase your risk for necreta because the placental sites are just building up little bits of scar tissue each time, which would make it easier for the next placenta to embed deeper. Okay, let's talk about postpartum bleeding. This pad kind of made me laugh because on the one hand, it's perfect if you're bleeding in that looks like you wouldn't notice if you'd stained it. But on the other hand, if we want to have a sense of how much someone's bleeding, that pad is awful. How would you know if it's saturated? So basically our lochia is moving through 3 phases. It starts out as lochia rubra, which is red, and then that moves to lochia serosa, and then lochia alba, which is white. So lochia rubra, that's the first few days when it's just really bright and red and is more that fresh blood. and then it's got some residual fetal cells and a little bit of decidua in there too, but looking like a really heavy period, so that first 3 to 4 days. And then we move into lochia serosa, and we're going to have continued blood here, but it looks more pink, and then we start to see wound exudates that are weeping from that placental site, mixed in with some leukocytes and decidua again, so that's what's composing it. I'm just going to skip back up to lochia rubra briefly here. So it's like we have a really heavy period, and then it kind of gets into more of a pink period, maybe pinky brown, and then somewhere in this 7 to 14 day period after the birth, it's not uncommon for mom's bleeding to just kind of pick up a little bit for a day. And, you know, we talk about how if women increase their activity, it's common for their bleeding to pick up because their uterus isn't able to contract as well. So that's a good indicator to moms if they're doing too much postpartum. So the more they're able to rest, then the more that uterus can just focus on getting back down to size. Whereas if she picks up her activity, then her uterus isn't contracted as well, and then you get more bleeding from the placental site. So moms always have that on their radar, but then it's not uncommon, say day 9 or 10, mom calls you and says, I feel like I've been resting all day long, but my bleeding's just been heavier today. Well, there's a good chance that that's because the scab that formed over the placental site has just shed off. So a scab or an eschar, what do we call that? I think eschar. Don't quote me on that one, but that's our placental scar. I bet all of you are watching this going, we all know how to say this word. Eschar? We're going to stick with eschar. Okay, so we build up a scab, and then the scab ends up sloughing off somewhere in a week to 2 weeks after the birth, and when it sloughs off, there tends to be a little bit of a pickup of bleeding, and then that stops over again. So know that there's a decent chance if it's like bleeding's just picked up a bit more than usual without an increase in activity, that's probably what it is. Okay, so then coming back to this serosa, it's not uncommon for it to just not smell that great. Sorry for all these little red marks here. My computer doesn't know how to say all these words. Okay, so mucopurulent doesn't necessarily smell that great, so we're going to call it somewhat malodorous, which you think about, especially if you should be sweaty, and to have it not smell that great, that's really, really, really normal. As opposed to it smelling like rotting meat, that would be my definition of a not normal smell. So you could suggest that she clean up. Maybe she went for a walk and then went to the bathroom and really felt like, ooh, this does not smell very good. Is there something wrong here? Say, well, why don't you take a shower, put on a fresh pad, spend a little time in that, and then see if that smell is persisting. And usually that should reduce it significantly, and wouldn't be so much of a concern there. So that's happening from about day 5 to 9 postpartum. So first few days, really heavy period, and then somewhere in the 1 to 2 weeks is usually when I see us starting to switch from more the pink to the alba. And it looks like I didn't give you a time frame there, but lochia albas, it's more like a yellowish white color, and it lasts from about day 10 to day 28 or so, somewhere in that range. It's primarily composed of leukocytes, decidual cells, mucus, bacteria, epithelial cells. So basically everything we have been seeing, but you start to take the blood component out of it, and then there's not as much wound exudate. So that piece is just dropping off. So sources really do vary in length for how long women have a bleeding postpartum, but the mean length is somewhere around 21 days, so about 3 weeks or so, but ranging up to 6 weeks. So usually when women are coming in for their 6-week visit, I'm expecting her to say, yep, my bleeding's all wrapped up, done with bleeding, and Maybe it stopped a week ago. Maybe she says, oh gosh, I was basically done by 2 weeks. I've been done forever. In which case you say, great, moving right along. Okay, so the cervix, it really does begin reforming immediately after the birth. It can take a little bit of a beating. It's just been through quite a lot of transition in a pretty short amount of time when you think about it. It seems like we're waiting forever for the cervix to dilate, but it really does undergo significant change, and it starts shrinking back down immediately afterwards, but not uncommon to have a few lacerations, it's edematous, bruised, etc. So generally for like the next week postpartum, it should be able to admit about 3 fingers, so it kind of hangs out around there immediately after the birth. And then by 6 weeks postpartum, most changes have resolved. And then sometimes the external os may be permanently changed. One thing I'll just note on this, it really does heal just fine on its own unless there's a really big, large laceration. You'll look at a cervix 6 weeks postpartum, and other than being able to see that it has this little slint, or slit maybe, as opposed to the dot, right, for having had a baby pass through it, you would never know that she just delivered. So nice and pink and ready to go again. But we do have our arteries that are running here at 6 and 9 o'clock, and if those end up with a deep laceration, those can really be blood spurters. So if you do have a mom with really heavy bleeding and it just really doesn't seem like it's coming from her uterus is nice and tight and firm, and her bladder's not enlarged, and you're trying to figure out where this bleeding's coming from, it's worth putting in a speculum and looking at her cervix and making sure you don't have a cervical laceration that needs repairing. So that's a possibility there. And then the other thing I just wanted to note for this slide is it really does start shrinking back right after the birth. And a couple times when I've had to do a placental removal, it can be hard. I mean, I need to get my whole hand in her uterus, and it already feels like we're down to being 3-4 centimeters again. Pitt can do that too. So you're giving Pitocin to try to get her placenta to come, and she's still bleeding, and you need to go in to get it. It can be hard to get back in because it's already shrinking down. So again, just something to be aware of. So ovarian function. What are we thinking when we're thinking ovarian function? We're wondering if her period's coming back. And basically, we've had ovaries that have been quiet, shriveled up raisins for all of pregnancy. Because we know that they kick in for us initially in early pregnancy, but then once the placenta takes over, the placenta is making all those hormones, and the ovaries are doing very little. So let's say a woman isn't breastfeeding. What are her ovaries doing in that case? So prolactin is what's released to cause milk production, which is our whole topic next week. Prolactin will fall to normal levels by 3 weeks if she doesn't start to breastfeed. So we're not breastfeeding, prolactin starts to drop, which in turn causes estrogen to rise. So by about 2 weeks, estrogen's picking back up. We know what estrogen does. Estrogen starts to, it's being released. Well, so if estrogen is even in there, then that means that FSH is stimulating follicles, and follicles are releasing that estrogen, right? So we already have follicles starting up, which means we can ovulate as early as about a month after the birth. So to be aware of that. So mean time to ovulation, if you're non-lactating, is 70 to 75 days postpartum, but being aware it could be as early as a month. So mean return to menstruation then is about 7 to 9 weeks postpartum. And once you hit 12 weeks, you've got the majority of women, about 70% of women, will have their period by 12 weeks. So again, the placenta comes out, estrogen and progesterone take a really sharp dive, because that was being released by the placenta. And then if we're not lactating, estrogen will start to rise again by 2 weeks, and then pregnancy can come right back around. So what if we are breastfeeding? So elevated prolactin levels prevents ovarian response to FSH. So if we're not releasing FSH, then we're not making follicles, and those follicles aren't releasing estrogen. which for postpartum women, estrogen's what makes our vaginal tissue nice and fluffy and stretchy and moist, and you'll hear postpartum women talk about feeling really dry down there. Sometimes we'll even do like an estrogen cream like Premarin if it's causing a lot of pain with sex. You know, they're a ways out from the birth and it's more just a matter of dryness, and lubrication's not enough. You know, just having low estrogen levels can be part of that, since prolactin is preventing follicles from being able to make estrogen, since FSH isn't in the picture. So during anovulation, the duration of anovulation depends on frequency, duration, and proportion of supplemental feeds. So I actually have a nice little calculation for you here. So what are the chances that we're ovulating if we're breastfeeding? If you're exclusively breastfeeding, your risk of ovulation is about 1 to 5%, even better than the pill, if you're nursing or pumping at least every 5 hours. So if they're saying, yeah, baby's sleeping through the night, got a good 7 hours, that 1 to 5% mark is going to go down. So not going more than 5 hours tops without nursing or pumping, which is going to cause that prolactin to increase, right? Which will make sure that we're not growing any more follicles if we have plenty of prolactin. So infant is only being fed mother's milk. So if baby's being fed other milk, then that means we don't have as much coming out of mom, which means less prolactin, right? Menses has not returned. If she gets her period, all bets are off. And we're less than 6 months postpartum. So this is a very effective form of birth control, assuming that we're less than 6 months postpartum and we're meeting all these other criteria. Oh, and I just put this little picture in here because thinking about low resource communities, that's a very cheap form of birth control. Breastfeeding is a very cheap form of birth control, and sometimes, well, obviously it's a very that goes without saying that it would be a cheap form of birth control. But just thinking about for women who are wanting to have more control, more power over their cycles, depending on what their access is to birth control or what their religious beliefs are around birth control, breastfeeding's pretty solid. And if they take it pretty seriously, you can get some pretty good birth control out of that for a while. So providing more education around what those parameters are that help to increase its efficacy can be really empowering for women. So, estrogen is so good for wound healing, and while we are lower in estrogen postpartum, the vagina, compared with the rest of the body in general, has a lot of estrogen around, and that helps it heal so well. That should be a huge encouragement for women. I'll see women with a 2nd-degree laceration that felt like a little bit of a mess to repair, and then they come back in at 6 weeks and it's like, oh my goodness, this looks beautiful. I don't put it in those words, but that's what I'm thinking. What we do postpartum oftentimes is more like cosmetic surgery, but estrogen is what takes the home run the full way. So, so thankful for estrogen in helping with wound healing here. Vaginal rugae often return by about 3 weeks, so we're all stretched out and then we start to accordion back up. Hymen presents by tissue tags, or you might hear them referred to as myrtiform caruncles. I never hear them referred to them as that, but now you know what the term is. Basically just saying that you did have this more firmer fibrous ring, and now it might be broken into little tags. So that can be something you can Google if you want to see what that looks like. Typically it's not an issue. Sometimes it can bother women, like I've seen it with dyspareunia or pain with sex. If it's like one of the little tags kind of gets kind of tugged at or kind of twisted funny, and if it doesn't have a lot of blood flow to the area or has like a really thin neck where it's connecting to her vagina, you could even just tie it off with a sterile string and then like cut it off essentially if the string doesn't make it break off. So that's an option that you could do as well, or snip it off if the blood flow isn't strong in that area. So okay, so that's our hymen. So vaginal muscles gradually regain tone. That's like the first 6 to 8 weeks postpartum. And then that's the point where if we're still in a rough spot, you can always send women to pelvic floor physical therapies. Some European countries automatically send all pregnant women to pelvic floor physical therapy. It's just part of their postpartum care. And I think that's a beautiful model. And I think the more we can be aware of our bodies and how our bodies are healing, the better. And that's empowering. So that's always an option. Be aware that even if people didn't have a lot of lacerations that were maybe visible to us, the vagina still underwent a ton of change. And while it's designed to do that, it can be a little bit traumatic for that tissue to heal, and women report pain even up to 3 months. So when they come in at their 6 weeks, we're hoping to just give them a big check mark and send them on their way. But if they are still having perineal pain, that can be really, really, really normal. So just to be aware of that. And I tell women the number one thing for figuring out, are you ready to have sex again, ultimately is how are you feeling? And they're going to know their bodies the best, and they're going to be able to have the best sense of what they're ready for and what they're not ready for. I had one midwife who would tell moms, no matter how long you wait, the first 7 times aren't going to feel that great. So there is some adjusting. I think that's a great way to put it. There is some adjusting, but it's okay to wait longer, I guess is what I'm saying. So if women are still having some discomfort there, just giving it more time to heal, soaking in the tub more, etc., all of that helps. Okay. And I think it's nice and protective that all major world religions have postpartum sexual prohibitions. So it's like built into them is having a little extra time to heal, which we'll take. So weight loss, something a lot of women want to ask about. So immediate loss of about 10 to 13 pounds right after birth. 28% of women return to pre-pregnant weight by 6 weeks. And then those that haven't gotten it by 6 weeks, it's about 6 months. So women who feel like they should be all the way back to normal by 6 weeks, most women aren't. I think a lot of this is just about providing reassurance of normalcy. If you gained a lot in your pregnancy, then you're more likely to have a net gain afterwards. And studies are kind of mixed, but there are studies to indicate that lactation can help facilitate weight and body fat loss. So it can be like 500 calories a day if you're at the peak of it. Depends on how big baby is and how much baby's eating for that time period. But breastfeeding is calories leaving your body, so that is a perk. Thyroid function. So we know that our thyroid got bigger in pregnancy, right? So the thyroid increased volume by about 30% in pregnancy, and then it takes about 12 weeks for just the overall size and bulk of it to kind of come back down. So again, that's not a nodular increase, it's just overall diffuse enlargement. Hormones from pregnancy return to normal within 4 weeks. So especially if you're thinking about a woman who came on board to pregnancy already having either hyper or hypothyroid, it's about 4 weeks postpartum that we're thinking we'll be back to our non-pregnant state, more or less. There's an increased risk for transient autoimmune thyroiditis postpartum. So that would be thinking about having very hyperthyroid symptoms and then that burning her thyroid out, and then that leads to hypothyroid. So that risk is there for about a year, and it does seem to have somewhat of a link with postpartum. Studies are for the most part indeterminate that I've seen for what causes that, but to be aware of that. So glucose regulations. So insulin needs change dramatically after the birth of the infant. So typically, like if a woman had diabetes, you would stop the insulin infusion at birth and then reassess need from there. Gestational diabetes will typically resolve rapidly. If it isn't resolving rapidly, we might want to explore if she may have had type 2 diabetes even before the pregnancy. But GDM should resolve right away. But then knowing that she does need more follow-up postpartum and then ongoing in life, as her risk for developing diabetes later in life is greatly increased. So cardiovascular system, remember we had a ton of changes in this system in pregnancy. So right after the birth, there's a big decrease in plasma volume. And then remember how we had all that extra fluid on board? A lot of it was in our blood, but then a lot of it was also in just extra spaces around our body. So our legs were swollen, etc. Our hands were swollen, our rings weren't fitting. We have all this extra fluid on board. So then at the birth, we lose a decent chunk of blood, so we have less in our blood vessels, but then all this extra fluid that's been hanging out in our third spaces starts to suck back into our blood vessels. So by day 3, it's about a liter. A liter of fluid is shifting from that extracellular into the intravascular space. And then we start making it disappear. So we sweat it off, we pee it off, really, really common. Day 2, day 3, women are just really wetting their sheets with sweat. They're peeing all the time. They're finding that new balance. So there's a few hemoglobin changes that take place. First of all, erythropoiesis to make more red blood cells. That is stimulated leading right up to the birth and then after the birth as well. So that's a wonderful protective mechanism. Thank you, God. Normal blood loss at a birth is somewhere in the 300 to 500 milliliter range for a vaginal birth. Over 500 is what we call a hemorrhage. We're starting to wonder if realistically that's more like 1,000, but for now we're still sticking with the number 500. We know that we're all horrible at guessing correctly as providers, that we all underestimate. But we're calling the number 500. It generally, blood loss isn't going to affect a woman's hemoglobin unless she hits 1,000 milliliters. Hemoglobin may decrease for several days due to that increase in plasma volume. So if you lose a certain amount of blood and then what's replacing it is all that edema fluid flooding back into your bloodstream, then it's like you have more plasma to red blood cells for your ratio, which is going to make your hemoglobin look decreased based on just the ratio there even. But having lost blood too at the birth. So interestingly enough, with vaginal births, there tends to be an overall 5% increase in hematocrit, whereas with C-sections, there's about a 6% decrease in hematocrit, which C-sections, you're not going to call it a hemorrhage unless you hit 1,000 milliliters, so we expect a higher blood loss with C-sections, and then you also have all the extra IV fluids on board, which might be responsible for that hematocrit change as well. Generally takes about 4 to 6 weeks for hemoglobin to return to pre-pregnancy levels. So that's what we're shooting for. Okay. So pulse and stroke volume are going to remain elevated for the 30-60 minutes right after the birth. And then we expect a little bit of a transient rise in blood pressure. So about 5% over the next 4 days. So just a little bit. Pulse is going to be your first indicator if you do have significant blood loss. So you think about what's the first thing I want to know if I'm thinking we're heading towards a hemorrhage. I'd rather know what her pulse is over her blood pressure because her pulse is going to tell me first. Okay, and then, excuse me, cardiac remodeling. So our heart underwent a lot of change in pregnancy, and that can result in the increased cardiac output for even up to a year postpartum in healthy women. So their cardiac output remains great and strong because of that remodeling, but most are going to return to non-pregnant values by 6 to 12 weeks postpartum. And then the greatest level of coagulability is that first 48 hours postpartum. So women really, they're born primed to clot, which comes with both benefits and risks. I mean, we had 0.5 liter a minute flowing to the placenta at the birth. So to have that placenta come off, we want to be able to clot it off. We have our uterus contracting to help clot off the blood vessels that are running through the walls of the uterus, right? But then we also need that blood to be able to clot. That's really important so we don't hemorrhage, and that's the number one reason women die worldwide around pregnancy is because of hemorrhaging. At the same time, it does put women at a greater risk for clotting. So being aware of that, getting her up soon after the birth. I'm not a fan of tons of activity because the more active she is, the harder it's going to be for her uterus to stay clamped, but we do want her to keep moving. The goal isn't for her to be a mummy right after the birth. Okay. Urinary tract and renal functions. Almost there. Hang with me, we're almost there. Sorry, guys. Dilation of collecting systems returns to normal by 6 weeks. So you hear that somewhere in the 6 weeks is coming up a lot. That's why most practices, your final visit postpartum is usually 6 weeks, maybe 8 weeks. So some women may have permanent distensibility of their renal pelvis and urinary stasis. That can be an issue that can arise postpartum following pregnancies. There tends to be a slight decrease in bladder capacity at 4 weeks. So prolonged labor can lead to that, as well as epidurals diminishing the bladder function transiently, and sensations can lead to that as well. Glomerular filtration rate returns to normal by about 8 weeks. And then the renal plasma flow is depressed for up to a year. Okay, so let's just take a look at that a little bit closer. So women who are postpartum are at a higher risk for having UTIs. Part of that is related to bladder and urethral trauma, over distension of the bladder as well, which catheters can sometimes be responsible around that as well, or if it was pulled too early, etc. Dysuria from superficial and perineal lacerations can cause people to not want to go to the bathroom very often, and then that can be part of that over-distension piece. Incomplete emptying. It can take a while for women to feel like everything's kind of back as they remember it. It can take a little while to pee that first time, but if those nerves are taking a little longer than is ideal, then incomplete emptying can be a piece of that sequela. Frequent use of IP catheters, which I already mentioned as well. So, and then stress incontinence risk during and after pregnancy due to strain on the pelvic muscles throughout pregnancy. So the weight of the uterus bearing down on those pelvic support muscles that we talked about earlier this year. And then obviously the pressure of pushing as well can put women at a higher risk there for stress incontinence. So other changes postpartum. So that hair growth that we had that was awesome in pregnancy is going to slow down postpartum, and that can look like hair loss. And then generalized transient decrease in bone mineralization. So lower calcium levels, that can be due to lactation as well. So typically once we're done breastfeeding, there's a rebound there and we end up higher than when we even started. So that's transient. Abdominal wall remains soft, and the return to normal can be gradual, and exercise can be a big part of helping women get back there again. Diastasis recti can remain. My general threshold is if people are 2 finger breadths or more of a gap. I'll send them to physical therapy if that's still where we're at by 6 weeks, but usually it comes together just fine without us doing a whole lot. And then women's striae, especially on their stomach, kind of turns a silvery color. So those are a few things to think about. So I just wanted to end by having us reflect a little bit on what it means to take care of postpartum women. I really think we drop them off too quickly. I think our CPM counterparts, certified professional midwives, that are doing the bulk of our out-of-hospital birth. For Minnesota, for example, their legislation has it where they have to do a minimum of 4 postpartum visits. I see oftentimes we hit them up in the hospital at least once before we send them home for a postpartum round, and then A lot of practices, you don't see them back till 6 weeks. I know some where, like at the birth center where I work at, we do a 1-day and a 3-day home visit, and then we see them back in the office at 6 weeks and as well as at 2 weeks. So they do get a few in there, but if it's going great, it's fine. If it's not going great, it takes us a long time to figure it out, like much longer than is really appropriate. Just thinking about that wide range of emotions, especially that are happening and the life transitioning that's happening postpartum. You have your placenta come out and all your hormones are just dropping quickly, and then you have this new baby, and if it's your first one, your world is turned completely upside down. And if it's your second one, I honestly think for a lot of women, the newness isn't raw like it was with the first baby, but trying to keep track of a toddler and a newborn is a lot of work and can feel like they're back to square one again. So lots of life transition in the midst of their breasts hurting, their bottoms feeling sore, they're sleep deprived. So a lot going on there that is wonderful as well as really hard. So wide range of emotions and wide range of life changes, like I've already said. So how well have we prepped them? How well can we prep a new mom? How receptive is a mom initially postpartum? Day one, I can't imagine feeling like we fully prepped her in pregnancy. Trying to provide a whole lot of education in the initial postpartum period, I think is a little bit of wishful thinking there as well. So we spent an awful lot of time with her all throughout pregnancy. She was seeing us every month, and then every couple weeks, and then every week leading up to the birth. And then what does it look like for us to be present with her in the postpartum period? I guess I should say we were very present with her for labor and birth as well. But what does postpartum look like? What does it mean to be present with these women postpartum? I just look around at this range of pictures. A lot of women super, super tired, feeling done with tears, full array of happiness and contentment. This is the mom where we give her a high five and realize that she's making all our other moms depressed, that she's getting back so quickly. And every woman comparing herself with every other woman, I think is a big deal too. So, okay. Well, I will leave you with that, and I hope you guys are having a great week.